You're welcome to another episode of Health Africa, and this episode is brought to you by the Association of African Universities, and my name is Isabella Teta Henakwam. You know, tuberculosis, which is also known as TB, is known by many of us, but we truly do not understand what it is. And although it is preventable and treatable, majority of the population still get the disease, especially in Africa. But the good news is that researchers are coming up with innovations to stop the spread and also to fight against tuberculosis. And in this episode, we are going to dive into one of these research or projects that is bringing together science, universities, and communities to address or fight tuberculosis, especially in Namibia. We'll go for a quick break. When we come back, I'll introduce our guest to you. Please stay tuned. You're welcome back from the break. If you just joined, this is Health Africa, and you can follow our discussions on our social media handles at Association of African Universities, both on Facebook and YouTube. And today we are discussing how African research is changing the fight against tuberculosis. And we are privileged to have here with us Libertina Shiweva, who is a research project coordinator at the University of Namibia. Hello, Libertina.
Hello.
You're welcome to Health Africa.
Thank you so much.
Great. Today we are discussing tuberculosis, but before we start the conversation, I would want you to briefly tell us a bit about yourself.
Thank you so much. Good day, viewers. My name is Libertina Shiweva, as she stated. I'm from Namibia, where I coordinate research projects in infectious diseases. There is a Center of Excellence in Infectious Diseases hosted at the School of Medicine in Namibia, whereby we conduct multiple number of research projects, ranging from mostly TB, whereby I coordinate one of the major projects in our university. And let me tell you maybe about my educational background.
Okay, yeah.
I have a master's in public health, master's in HIV and AIDS management, postgraduate diploma in project management from Stellenbosch University. And so I have been coordinating these projects for the past 5 years. Whereby, I'll tell you more about the project soon. So thank you so much, and I'm glad to be here today.
Thank you too for coming to our production today. Now we are discussing TB, and like I mentioned in my introduction, we all know about it, but we truly do not understand what it is in terms of its infection, and also currently a lot of people are still getting infected of TB. So if you tell us what tuberculosis is with your perspective, and also why we are still getting cases of tuberculosis.
Thank you so much for the question. In a layman's language, I would say tuberculosis is a transmitted disease that can be passed from one person to another through coming in contact of the, if maybe somebody is coughing and then the next person get infected. So it's in different stages, and this also includes multidrug-resistant tuberculosis, whereby the body is not able to fight about whether they take drugs such as azonate or rifamycin. The body is not able to take up the drugs so that the disease get treated. So, however, it's curable, and the researchers are busy doing more on how to really end transmissions of tuberculosis. As per even the WHO NTB goal strategy, by at least within 2035, TB should end, especially in Africa and across the globe.
Really? Yes. So if by 2025, right? 2035, TB should end.
Yes.
Currently, we know it is treatable, like you said, and also preventable, but a lot of people are reacting in terms of they take the drugs, but it is still not working. And that is what they term the MDR-TB, multidrug-resistant tuberculosis. Majority of us do not really understand what it is. So if you can, in layman's terms, explain into details what the MDR-TB is.
So MDR-TB is a type of TB that is transmission through strains, and it's not curable. So even if the person take drugs such as I said, azonate and rifamycin, the body is still not able to take up to fight against the disease. So it leads to the body not to be able to fight the disease, and this is one of the major issue we have because it's highly transmittable to the next person.
I think it's related to, we do hear medical experts advising us to stop taking antibiotics when you are not prescribed, because your body will get used to it and later the antibiotics may not be. So it's quite similar.
It's the same concept.
Okay, great. Now you keep talking about our project. So if you can tell us what this project is about and also what problem you are solving.
Thank you so much for that question. So H3TB stands for hotspot, households, and hospitals, whereby we are focusing on active case finding in communities in the most three highly burden regions in Namibia. So we are finding cases actively by going in communities, by going at households, by going at different hotspots where the MDR-TB patients come together and engage in communities. So there is a difference between passive case finding and active case finding. Passive case finding is when we wait for the patients to maybe start coughing for more than 4 weeks as per the TB prescriptions, categories of identifying the disease. So once the patients see that I'm not feeling well, then they go to the hospital. That's passive case finding. So active case finding is us going to communities so that we find these cases. So the reason of the project is to end transmission and so that we can at least contribute to the WHO NTB strategy by vision 2035. So Namibia is one of the highly burdened TB country, ranked number 11th by the WHO. Ranks, number 11. Worldwide. So we have 3 regions such as Ochodonjupa, Comas, and Ohangwena, where there are a lot of MDR-TB. So we go to those regions and find these cases. Yes.
Okay. So it is hotspots, households, and hospitals.
Yes.
And I would want you to take us through the 3 steps.
Yes.
So you find the hotspots.
So we have one of the major project surveillance study, whereby we wait for the different nurses in different regions to tell us where are the MDR-TB patients. So when they give us case notifications, for example, in Comas regions, we get case notifications in Comas region, and then a patient is admitted at the hospital. So now the visitors to the patient, we interview those patients and take their blood samples. We take them to the laboratory, which is also at the University of Namibia, at School of Medicine, and do their lab tests, whereby we also do whole genome sequencing, analyzing the data so that we can see which drugs can be recommended to these patients so that we can end the transmission. That's now on hospital. Household, the MDR-TB index patient is in the communities. So the houses where they live, the people they live with, we go to communities and interview those people. We go through with them the structured questionnaire and also take their blood samples for the purpose of the study. So, and then on hotspot, these are places where the MDR-TB patients go, such as church, water points, in communities, cooker shops. So these places, we again go through to the communities. So this includes a range number of different people in the communities. So, and then we interview them, same process as we do at the hospital and the hotspot household.
Great. Well, I told you we have good news. Our researchers are coming up with innovative ways to, address fighting against tuberculosis. And this time, we are not waiting for you to get the symptoms, but rather come to you to interview you, get your samples, and go and do the lab. Thank you very much for sharing this with us. Now, so I went through the project and I saw that as part of your activities or your research, you work with genome sequencing alongside geographical and also social network mapping. We would want to know how these 3 works together.
Okay, thank you for that question. That is one of the questions that I'm also dealing with in my early starting PhD, whereby we want to combine the whole genome sequencing data to the spatial location distribution of tuberculosis. So when we go in communities, we take the geographic coordinates store them in the devices that we use, the tablets, and then later on we merge those two data so that we can see which patient is allocated where and from which strain or from the next generation sequencing data. So we are doing that so that we can end the transmission from within communities and to reduce the gaps in not finding cases in Namibia.
Okay, right. You know, there are a lot of research there, especially from undergrad, masters, and PhD, and we really do not know where the findings or even the recommendations students and research project managers come up with. We don't know where these goes to. Now, how will your findings from these projects that you are doing going to influence policy uptake in terms of policy decisions to ensure that it is not just for a period? A project has timeline, so it's not going to end when the project ends, but rather the government is going to take and make sure it is implemented, I mean, for a very long term.
Thank you so much. So, if you follow very well, in every African country, let me say in every country, there is a national tuberculosis and leprosy program that is embedded in the Ministry of Health and Social Services. So we also have that in Namibia. So one of the major concepts that we are dealing with in Namibia is collaboration, especially on this project, whereby we work closely with the NTLP in Namibia. And we have been working with them from formulating of this proposal for this project so that they are aware of what is happening, to ethics application for the project. So they know very well about this project. So how are we making sure that this leads to the impact in community? So firstly, we publish our findings. That's one of the output from the project, such as with journals such as the BMJ Open. So if you have seen, one of the protocol is already out on the BMJ journal. So that's let me say that was our first publication. So secondly, we are also still publishing. That's on publications, so we are still publishing. A lot is still going on within the project, and such as we are coming up with the model to see how we can end these transmissions. So it's still ongoing. So how do we make sure that our findings are embedded in the policies and frameworks and regulations of the Ministry of Health in Namibia? So we give them our results, then we give them our recommendations, and then when they are going to review policy review, for example, on every 5th year or on every 3rd year, they embed those new changes, those new technologies, such as, for example, recently we have made changes in our tuberculosis MDR-TB guideline on how the healthcare provider should treat the TB patients. Now there is next generation sequencing embedded in that new guideline. So that is one of our successful story, which is impacting community at large. So we will continue doing that, so that, because we have, the problem is not about finding cases, it's about there's a research gap that need to be filled. So we are busy filling that gap.
And what's that research gap, if I may know? What's that?
Where is the research gap? The research gap is that although a lot is being done with regards to MDR-TB and TB in general, we are still missing cases of TB.
Right, now, before we go for break, I would want you to know, I mean, you are very much interested in Namibia, trying to, solve your health challenges in Namibia. And this our platform goes beyond. It reaches a lot of people across the continent and even beyond the continent. Now, if someone watching us today is interested and want to know, okay, how is this findings also going to, try and fight against TB in other countries beyond Namibia? How would they adapt to your findings?
They are, thank you for the question. They are likely to adapt to our findings by reading most of our articles. Like I said, the protocol is already out, published in BMJ Open. So they can adapt that and they can always reach out to us. And we also give outputs of our findings at major conferences such as the Union Conference that happens globally every year. So most of our students, master students and PhD students, and even the principal investigator of the project always present at these global stages. So one thing that I should tell you is also that we are busy collaborating with other international collaborators. such as the Imperial College of London in London, such as the Stellenbosch University in South Africa, such as the National Taiwan University in Taiwan. So we are not only alone. So it's a collaboration going on.
All right. Thank you very much, Libertina. We'll go for a break. When we come back, we shall dive into collaboration and other aspects of H3TB.
Thank you so much.
All right. We'll go for a break. Please stay with us. You're welcome back from the break, and this is Health African. Today we are discussing how African research is changing the fight against tuberculosis. Specifically, we are looking at H3TB with Libertina Shiweva, who is a research project coordinator at the University of Namibia. Hello, Libertina.
Hello.
Thanks for staying with us. Now, before we went for break, you were telling us the people or stakeholders you collaborate with. You made mention of Stellenbosch universities as well as other international stakeholders. Now, we would want to know, aside these, which other stakeholders do you collaborate with? And possibly let us know the role they play in the project.
Okay. Thank you so much. So one of the collaborators that we work with is our laboratory test agency in Namibia, which is the National Pathology Institute, whereby, as I told you, that we collect blood samples and sputum. So when they notify us index patient cases, they also give us in laboratory tests, there's something called the culture results, testing the sputum to see if they have TB and so on. So we work closely with them, whereby they give us also those results, so that we can take it up to confirm our cases and go in communities and find the cases. So another collaborator is the National Tuberculosis and Leprosy Program in the Ministry of Health. So the Ministry of Health is the custodian that we highly collaborate with. And we are also collaborating with different universities in Africa so that we can make sure that we network and collaborate and come up with even new projects again, and not only focused on the H3TB project. So collaboration is very important, so that you just don't solve the problem at your community level, but on a global stage at large.
And you collaborate with the community and with the ministries.
Yes.
You didn't really tell us their role. Do they give funding or maybe expertise, or what's their role, the ministries and also the communities?
The ministry's role is to inform us about the active cases that are happening, the index patient cases. So once they inform us, then we go to communities. So when we go communities, the ministry have TB promoters that works under the Ministry of Health. So for example, if we go to a certain region where we don't understand their local language, the TB promoters are able to even tell us where the patients are, or translate to them about how we are asking them in English and translate it to their local languages, so that the participants is able to respond to us. So that is one of the highly way we use. And we also collaborate with directors in those different regions, the nurses in those different regions and different hospitals. So that's how we highly collaborate in Namibia.
Now, let's look at challenges. We'll first look at funding. I mean, when you approach any researcher, you ask, what are your challenges? The first thing they talk about is funding. But in your submissions, you never mention of funding. So I want to know, are you funded for these projects, or maybe it's an initiative by the university, funded by the university to, make or implement these projects?
Thank you so much. This project is funded by two funders. One is the EDCTP. You know EDCTP? Yeah, we can look at it later. EDCTP2 is one of our funders. And then also the British MRC, the British Council, is also one of our funders for this project. So we are fully funded, and everything else depends on funding. So one of our challenges that we ever experienced in this project was the delay of COVID-19, whereby we had to wait for the COVID-19 challenges to cap down, so that we can be able to travel and go to communities, and also even to go to different conferences. Some of the delays were delayed. So that is one of our major challenges at the onset of the project even. So the second challenge is, let me say, language barrier, with different patients that are not able maybe to understand their language, or maybe even some of our patients are even from Angola. So that is one of our challenge, but we have a translator that can speak that language. So we are, at the same time, we are experiencing the challenge, but we are also tackling the challenges. So another challenge that we have experienced so far is maybe just delays in timelines of the project. But as I have said, to implement the schedule so that the milestones are achieved. But although we are experiencing that, we have to make sure that we achieve the milestones of the project.
Okay. Now, I know as you were engaging the community, of course, there are lots of misconceptions about tuberculosis. I mean, per my experience, one I can share is when we see someone coughing, we'll be like, hey, don't come close to me because you may be having tuberculosis. Now, if you can share with me some of the misconceptions you experience through your engagement with the community and even with the hospital, some misconceptions you can share with us.
Thank you for that question, because some of the misconceptions, they happen almost every day. As I told you, we collect blood samples. So it's sort of a challenge to really collect blood samples, because there are misconceptions in communities out there where people just think maybe we are just there to collect their blood, just to go develop new diseases, such as maybe related to COVID-19 or hantavirus. But it's not like that. It's mainly for to prevent transmissions, so that we make sure that these patients that we are finding during the project, they start treatment so that we end transmission in community. So that is one of the misconceptions. And another misconception is maybe that it comes back to the terms of culture. So in different cultures, some people don't want maybe to even talk to welcome new people in their communities. So there is that hesitancy of welcoming new visitors to their communities. So that is also one of the misconceptions. So, but we have all the ethical approvals. So if we introduce, for example, the studies, different studies, this can also be adapted by other studies in communities where you tell them exactly what the study is all about, and that is supported by your ministry in your different regions. People are able to understand all these items, and they will be able to welcome you for the impact of their community.
Maybe if I can share, probably when you go to the community, I know maybe that's how you do. When you go to these communities, especially the rural areas, you first see the leaders of the community to engage with them. So the communication will first go through the leaders to the community before you even explore or taking the injection. Of course, I want to be at my home and then you come and say, hey, I want to take some blood, and I'll just freely give it to you. Some education needs to go on. Thank you so much. So we may have some researchers watching us who will be interested, young researchers, will be interested in taking initiatives like this, and not just doing research and it will be, hidden in a shelf, but rather, move forward to implementation, to influencing policy decisions, seeing the impact of their research. What would be your advice to a young researcher watching us today?
Okay, my advice to the young researchers watching today is just that don't give up. There are a lot of challenges out there, especially in research backgrounds. There are a lot of challenges that can even make you want to leave everything. But being resilient always makes you achieve more, higher and higher, and soaring on like an eagle. So, and also one of the advice is that, for example, Nelson Mandela once told us that education is the greatest equalizer. So keep going, keep studying, keep researching. So surely you do this for the purpose of the impact of the community, and at the same time, you are also enriching yourself so that you keep climbing the ladder.
Okay, and if you are given the opportunity to talk to the government, before implementation will go on, the government needs to accept your findings. And so if you are given the opportunity to approach or speak to the government, what will be your 3 priority investments that they should focus on when it comes to fighting against tuberculosis?
Thank you so much. So if I'm given a chance to speak to our government or any other government, I would tell them to consider firstly universal health coverage, whereby they need, for example, for us, we find cases. So we are only focusing on 3 regions. So if the government can focus on the rest of the regions, so that will yield in universal coverage being accomplished. And secondly, the government can invest in educating communities on how to prevent diseases such as tuberculosis and other diseases, other communicable diseases. So education is really important in our communities. So this will create awareness in communities, and people will be aware of what to do and not what to do. And the third one to the government is just to for the government people itself to also just keep going. So that would be my advice to them.
Okay. And lastly, to the communities who are the beneficiaries, of course, they need to understand and be aware, and also to accept it before we can mark our KPI as, done. And so what would be your advice to the communities?
My advice to communities at large in different countries, in different global countries, is just that most of us are afraid of change. They must embrace change. When new innovation come to them, they must embrace change and accept it, and just know that there is no hidden agenda behind, but it's strictly for the impacting community at large, so that we end these strategies, so that the communities, we live in a healthy community, and a healthy community is a thriving community.
Okay. Great. Libertina, before we wrap up, if I'm to ask, in the next 10 years, are you confident that Africa, we have moved, like you said, 20, okay, so it's actually 9 years. Yes, in the next 9 years, do you think Africa especially would have met the goal, or what the mark by the WHO that by 2030 we should end tuberculosis? Are you very confident we'll reach there?
I am very confident because they are always, for example, in terms of policies and frameworks, they are always being reviewed for this for impacting community. The policies and frameworks are always being reviewed. There are always new innovative ways of testing tuberculosis. Sometimes they are even now you can even swab somebody on their tongue just to test tuberculosis. So those innovative ideas are really helpful on contributing to the NTB strategy, and even mobilizing communities, campaigns, and awareness. They are really helping communities to understand that this is really for the sake of us, so that we have a healthy community. So I strongly believe that in 10 years, 9 years, I'm sure there will be a reduction of cases. For example, in Namibia, our cases stands at 226 per 100,000 people, whereby every 100,000 you are likely to find every 226 person they are likely to be TB patient cases. So with all this that we are combating, we are able to reduce transmissions and then reduce the levels of which each country is being listed as per the WHO listing. Okay,
thank you very much, Libertina. Thank you so much for coming to Health Africa and also sharing this groundbreaking project with us. We hope to engage you again, maybe virtually, to get the update of this project and also what's next in terms of other infectious diseases. Thank you so much for coming.
Thank you so much.
Great. And this brings us to the end of today's discussions, where we talked about how research is shaping the fight against tuberculosis, specifically H3TB, which is hotspots, household, and hospital. And we did this with Libertina Shiweva, who is a research project coordinator from the University of Namibia. And also the principal investigator of the project is Professor Marie-Lee Claessens, all at the University of Namibia. As said, we are moving beyond passive treatment to active one, and so a lot is ongoing. My name is Isabella Teta Henako, and we hope to see you again in our next episode. Do have a great day.